women who have a normal functioning pelvic floor don't need to do Kegels, don't need to do pelvic floor muscle training just because they're pregnant or just because they've just had a baby. So sometimes, unlike you, sometimes we'll assess a pregnant woman's body and we'll go, yours is brilliant, don't worry about it. So whilst I didn't want you to do any because yours was so dysfunctional, you would have made it worse with the way you're doing your exercises. Sometimes they're so good, we say, don't worry about it. Like, yours works. We don't need to rehabilitate that. We don't need to do anything with that. When we are assessing a pelvic floor, we're looking for where the deficit in their function is. Could be strength, could be coordination, could be resting tone, could be ability for it to contract automatically before that cough or that foot lift or that curl up. And then we decide what the program will look like for that individual person.
Welcome to The Body Never Lies. I'm your host, Leela Lutz. Each week, myself and experts from around the world help you uncover the secret ways your body communicates with you to empower you in your own individual health journey. Now, as you can hear from that little snapshot, there was something that I put off for years and years. I had a super tight pelvic floor. It needed manual therapy to release it and retraining on my part to get it functional again. And it wasn't until I wanted to have a baby without any intervention to be able to protect my precious parts and my future and all the lifting that I like to do that I did something about it. It was a bit like an accountant not doing their taxes, but hey, you know. Now, Joelene Murdoch and Tamara from the Physiotherapy Clinic were the two women who were integral in my journey to overcome years of dysfunction, have the birth I wanted, and come back to lifting and training even stronger than before. They also look after a lot of my Sydney clients, some without babies, some during pregnancy, and some many years and years after the fact. Like most topics on this show, I feel there are a lot of misconceptions about the pelvic floor and the abdominal wall, as well as a barrage of programs and prescriptions that misunderstand it, confuse the consumer, and oftentimes make it worse. So today, on The Body Never Lies, Tamara, Jo, and I are diving into all things pelvic floor and the abdominal wall.
Well, today on The Body Never Lies, I've got two amazing physios that I have the pleasure of working with, Joelene Murdoch and her partner in crime, Tamara Woods. Thanks so much for coming on the show, ladies.
No worries at all.
Thanks for having us.
So I guess we should start with, how do you become so interested in pelvic floor and have that as your specialty? Jo, do you want to start?
Sure, yes. Well, that's quite simple, actually. How that happened for us was that we were already treating the whole body, but particularly the outside of the pelvis. So after doing that for a little while, you quickly realise that if you really want to understand the pelvis, you've got to understand what's on the inside of the pelvis, because what's on the inside is very complex. So obviously part of that is the muscles, part of it's the fascia, part of it's the organs. So that's pretty much how my journey started, which was just a few years before TAMS. But and once understanding that, just over time, you continue to realise the level of importance of understanding the pelvic floor if you really want to treat someone's body well.
Yeah. And I think, I was always taught as a Czech practitioner how important it was to work with a therapist who did manual internal pelvic floor therapy. So I was so excited when I found you guys. Tamara, are there many pelvic floor physiotherapists who work at that high touch point like you guys do? Like, you guys, we'll talk about that more in the show, but I've never come across physiotherapists that work at the level that you do.
Oh, look, I think hopefully more and more, I think these days, definitely, we're all trying to do our best. And I suppose when you first start learning, it's just, like Jo said, a lot to learn the rest of the body, let alone the pelvic floor. And then it's a lot to learn what's what's going on with the pelvic floor and certainly how the pelvic organs link in with it. But I think, of course, you need some time up your belt. So years and years of looking and, assessing and treating in order to, I suppose, get to the level where you can link lots of things in together. But I think there's a lot of education out there now to try and get hopefully most women's health physios up to that level of being able to pick the little nuances in the pelvic floor.
Well, this series is all about the myths, and so I really wanted to have a look at the myths of pelvic floor being a woman's pregnancy and continence issue. I think that's generally when people think of having their pelvic floor looked at. Whereas I've had many clients who are, in their early 20s, not interested in babies, who I've needed to refer out to get pelvic floor work done, athletes, many women in their 40s and 50s who never had treatment through birth, post-birth, didn't know there was anything wrong with them, and then all of a sudden there's an issue that comes up. Let's just have a look at, talk about the pelvic floor and its function and why it's important throughout life, not just related to pregnancy.
Yep, sure. I'm happy to take this one, Tam, if you like. Okay, well, I think to start with, I suppose we've just had the privilege of being able to, as Tam says, assess and treat a lot of pelvic floors. So certainly when we first started, probably we, like most of the community, just assumed that if you didn't leak urine, your pelvic floor was really strong, and a strong pelvic floor is a good pelvic floor. But it's just nowhere near as simple as that. So the first thing, sort of myth to bust, if you like, is that actually the pelvic floor muscles are just a secondary mechanism to continence. So the sphincters around and inside the urethra are your continence mechanism. So you can have a pelvic floor that doesn't work at all, very what we'd call dysfunctional, and still be continent. And so that's confusing for people because therefore continence doesn't mean great pelvic floor, for one. And in terms of its other functions that people don't understand, probably their bigger function is to assist the fascia and the ligaments to hold up our organs. Yeah. So their role in that space is sort of far more important. And that's why people like you and other personal trainers are so great at referring their clients on who you are suspicious might have some sort of pelvic floor dysfunction, because we want to be able to pick that up before, not it's too late, but before potentially their organs, the position of their organs are suffering from not having a good support system underneath. So really the pelvic floor muscles play an enormous role in supporting our organs. Yeah. And they also, we think, do play a role in our postural system, if you like, or our stability system. So they're deep inside our bodies and they're connected to layers of muscle that are also deep inside our body, and whose job is to just kind of keep us upright, keep us stable, and keep us functioning well. So they have sort of three layers of importance, if you like.
And I think, like for me as a practitioner, I'm always looking at the relationship with the pelvic floor and the rest of the body, so the diaphragm, and a lot of people in my sphere, the Czech sphere, we would consider the bodies having like 7 diaphragms and the pelvic floor being one of them, and all of them having to work together for that postural stability, like you say, that stability moving through space. So especially if I'm treating someone or working with someone who doesn't have great pelvic stability, I really want to know from you guys, like, what's the relationship between the internal stabilizers and the external stabilizers, especially if someone's got like a recurring sacroiliac joint dysfunction or, an AIS or anything like that. I can't tell myself what's going on inside. I can palpate the external wall, and I think a lot of personal trainers can do that. See what's going on in a lift, but to actually get a feeling of what's going inside, that's where you guys come in and have been so helpful with my clients. So I think a lot of people view it as a birth problem. But can you talk maybe, Tamara, about what's happening, in younger women before birth? I feel like women don't get it assessed until after birth, right?
Yeah, 100%. I mean, we would argue, and even the Australian government has come out, which just makes me so excited, and to say that women should get assessed when they're pregnant and, start treating their pelvic floor when they're pregnant. So not just postpartum, of course. But that's not the only time. It's not even just around pregnancy, is it? Or postpartum. It's even before that. So you can have a dysfunctional pelvic floor for lots of different reasons. In your earlier years, I think the one we probably see the most is women who have heavy, painful periods. And so a lot of pain, obviously, in and around their pelvis with that period every month. And pain in any region of the body makes muscles tight. And it's the same here. So if you're cramping and you have pain at the front of your pelvis or your lower abdomen, then their pelvic floors appear to become tighter and tighter over time. And then, of course, tight muscles equal pain. So we see, therefore, a tighter than you should have pelvic floor in those women. And that often comes out as symptoms as, well, just ongoing pain in and around their pelvis, almost like that period pain, but not with their period. And things like dyspareunia, so pain with sex, and even other strange things that start to affect their bladder, so symptoms in their bladder as well. So they're the types of things I suppose we can see in women before they're even close to becoming pregnant or having babies.
Mm. And so I couldn't speak personally too, and I never did anything about it until I was pregnant. So I needed the extra motivation to do it. Yeah. Was that, I had a super, super tight pelvic floor. And I knew that from my hip dysfunction, because I know enough about hip dysfunction, but also just things like having pain with using tampons, getting a moon cup stuck, not being able to get it out.
Yes, that's happened to me too.
Yeah.
It's quite concerning, isn't it? For a while, you're like, I thought I might have to call Joe at one point.
I think there was a really funny blog on it. This woman like having a glass of wine, trying to get it out, like trying to relax.
Seriously, though.
And this is a sign of a really hypertonic pelvic floor. And I finally, when I was pregnant, really, really, really knowing about birth and physiology, wanted to have a natural birth. And so finally went, okay, I'm going to book in with Joe and get this pelvic floor worked on.
And so fun it would have been, I'm sure.
Oh, well, yeah, it was pretty wound up and full of trigger points and an adventure to go on. But it's interesting, right, because your prescription to me was to not do any pelvic floor exercises.
That is true.
Yeah.
You're not good at it. No.
Can we sort of address the Kegel and the myth around the Kegel exercise, Jo?
Sure, I would love to. First of all, I hate that word. Who's Dr. Kegel? Okay, sure. I respect the fact that man realised there were muscles inside the pelvis. That was good. And then realised that they should work well. That's great. But why on earth we have kept the term Kegels, I have no idea. As an American gynecologist, I think. So we never call them that, and we correct our patients if they do. Oh, you mean your pelvic floor muscle exercises? So the reality of the pelvic floor muscles, for those listening that are health professionals, you'll know them as the levator ani. They are, as I said, part of the postural muscle system. So therefore, like the diaphragm and like transversus abdominis, they work automatically just when they're needed. So the right amount of activity is turned on at exactly the right time. Yeah. And then they'll just sit at a really nice resting tone for the rest of the time. So if you cough, if you increase the intra-abdominal pressure somehow, like a cough or a lift, or you just walk on a slightly more uneven surface, you have to use your muscles a little bit differently, well, your pelvic floor will adjust the way it responds to that by increasing its activity a little bit more. So if you think about normal behaviour, then women who have a normal functioning pelvic floor don't need to do Kegels, don't need to do pelvic floor muscle training just because they're pregnant or just because they've just had a baby. So sometimes, unlike you, sometimes we'll assess a pregnant woman's body and we'll go, yours is brilliant, don't worry about it. So whilst I didn't want you to do any because yours was so dysfunctional, you would have made it worse with the way you're doing your exercises. Sometimes they're so good, we say, don't worry about it. Like yours works. We don't need to rehabilitate that. We don't need to do anything with that. When we are assessing a pelvic floor, we're looking for where the deficit in their function is. Could be strength, could be coordination, could be resting tone, could be ability for it to contract automatically before that cough or that foot lift or that curl up. And then we decide what the program will look like for that individual person.
And so I think it can come, do you think flexibility index is a good indicator for what kind of pelvic floor you might have?
So whole body flexibility, you mean?
Yeah. So when we talk about the Roccabato's in index, for instance, someone who's got very hypermobile, so that's me, very, could bend my elbows backwards, hyperextend knees, that kind of thing. And these people tend to love yoga because they can put all their limbs everywhere and they feel really good. And then you've got other people at the end of the scale who have can't touch their toes to save their life.
Yeah.
So on that sliding scale, just for lay people to understand, is that are you guys seeing that as an indicator of whether someone will be hypertonic?
Yeah. Yeah. I'd have to say yes, because we are seeing lots of women more and more recently with either hypermobility syndrome or Ehlers-Danlos syndrome. And you would think, I think most people assume that because their tissues are lax, that their pelvic floor is going to be lax as well. But of course, it makes far more sense that their pelvic floor actually goes into that hypertonic state because it's compensating for the laxity in the fascia inside the pelvis, which is called the endopelvic fascia. So the fascia inside the pelvis is a little bit more mobile than normal because of their connective tissue disorder. And so, of course, the muscle system goes, zhook. That's what we find. It's tight and generally speaking dysfunctional, so doesn't really move well, doesn't contract or relax well.
And I think too, like with those hypermobile people, there's a lack of understanding in training and exercise prescription on how to get those people super, super strong in those global stabilizers so that we can give those little internal ones a break. So, I always tell people it's like it's a relationship, right? Like one has to hold, the other one has to help. And if one's doing more work than the other, it becomes an imbalance. And that's where you see these super tight pelvic floors, like something's got to hold your pelvis together, right? Otherwise you'll literally fall apart and have all these pelvic injuries. So in terms of looking at birth then, how is our pelvic floor going to affect our birth experience? Do we have, you guys have worked with so many women through their pregnancy, after their pregnancy, and I always really make it clear in this podcast is there is research, but then there's also people who are in clinical practice treating women every single day and treating patients, clients over a long period of time that goes well beyond a research study that's ever been done. So, if I had another baby, I'd be back with these guys through that second pregnancy, third pregnancy. So I think the clinical data that you're collecting is like greater than any research project.
I like that word, clinical data.
So what are you guys seeing in terms of women being treated before they give birth and what their birth experience is like?
Honestly, it's hard to, look at a pelvic floor, even one that you think is perfect, and equal that to any certain birth experience, I think, because birth is just it's just affected by so many different things. But I do strongly believe that you should get your pelvic floor to be the best that it possibly can be when you're pregnant before the birth, because it is, we think at least, one of the things that could contribute, I suppose, to failing to progress or to not have the most efficient birth that you possibly could have. And plus, it's one of the things that you can change, I suppose, and you can, control to a degree. And there's a lot in birth that you can't control. So controlling the controllables, I think, is helpful for your mind, because even if it doesn't turn out the way that you wanted it to be, your birth, I mean, at least you did everything you could to make it be the most efficient thing that it could have been. It's nothing worse than not knowing that the pelvic floor could have been a contributor and having done nothing about it. Does that make sense? And certainly, of course, it makes sense to us, and our clinical data would suggest that that if it is short and tight and hypertonic and therefore does not move well and does not let go well, then, the only thing it really needs to do is get out of the way. It needs to drop, it needs to open, it needs to get out of the way so that the baby can travel down and through and be born efficiently. That being said, we are thinking these days that it doesn't just need to be really low tone either and just get fully out of the way. Yeah. It needs to have a teeny bit of resistance to exit, because it does assist the baby's head, we think, to extend out and through and then rotate as it's crowning. So not too tight, not too loose, somewhere in the middle.
Well, I certainly had Joe's head in my birth when I was birthing.
Your pelvic floor was amazing by the end. It moved so well. You could bear down so well that, both of us went into your birth thinking, this is going to be all right.
I was excited.
I remember it.
a little bit too excited. And I think what I got from you guys when I was in birth, and we can talk about, I really want you guys to talk about your birth course towards the end, but was really having an understanding of physiology and what happens to the uterus in labour and what's happening to the pelvic floor. And the thing that stuck in my mind when I was in labour, I remember crowning, and Joe's voice in my head was, don't push. breathe through. Like, if you feel that, just to breathe at some point, stop. Like, don't always push. And I think that saved kept me intact for all the non-medical people listening. So thinking about birth and that kind of experience, like quite a lot of women do experience tearing and, injury. Let's call it an injury, because it is, from birth. How do we start addressing that? Because I find what is really upsetting to me is that so many women carry this injury and don't do anything about it. And quite often, I don't know whether that's because they just have a GP appointment or a gynecologist appointment. I feel as if the scar and the healing in terms of infection is addressed, but the return of function is not addressed. And how important that is to be done in the early stages before we start adding load to an area that has damaged tissue and damaged reflexes and all that kind of stuff. Did you want to talk about that, Tamara?
Sure. I think, again, yes, it isn't addressed. Lots of women will have, there's different degrees of tearing, of course, some not as bad as others. So majority of women will have a first degree tear and maybe even a second degree tear. It's the third degrees and obviously the fourth degree that isn't so optimal and certainly, generally speaking, needs to be repaired. We would hope in theatres at the hospital. First and second are repaired in the rooms. That's fine. And I agree, in terms of the wound healing, that's definitely dealt with quite well by the doctors, and that's their role. In terms of what needs to be done otherwise, it does depend, of course, on the degree of tear. And I think because we're not in the hospital system quite so much, we see, I suppose, more the first and the second degrees, a bit of the third and the fourth. But even with those, I do find that, women just don't want to look at it, don't want to think about it, don't want to see it, and then are very worried about having sex. And if it hurts when they have sex, they're thinking in their mind, even though they've been cleared and they say it's, you know, healed and it's good, that it's going to rip or it's going to open. And obviously it totally makes sense that this injury isn't as mobile, the skin. It doesn't give as well as it did before. And of course, there's lots of little nerves that's been cut through too, or rather torn through and stitched back up. And those little nerves, they grow back, which is great, but nerves are funny little things. And if they think that you don't like them and then they're never touched and you don't treat them as per usual or normal, I don't think they don't behave normally. So I think I'm often, I don't know about you, Jo, just telling people to, you know, massage it a bit in the shower, to touch it, to feel it. And if they do have sex, to expect, I suppose, a little bit of pain, at least that first time. But in their mind, to just say, it's okay, it's okay, and see what happens from there. And of course, in clinic, we're massaging it for them and telling them that it is okay. This is okay. This is going to get better and it's going to be fine and it's going to feel normal again.
Because it is unfortunate. I do talk to a lot of women who say they have a loss of sensation after childbirth that lingers for years. And sex never feels the same externally, sometimes internally. And I feel this is a bit sad for women because it's really disempowering, right? Like,
yeah, it's awful.
The loss of your sexual self as well, and not feeling comfortable in that area anymore. And yeah, I think that how can we treat women, you know, years post-birth with those issues?
I think we can, because I think a lot of it is just lack of knowledge and not knowing something, and then it not feeling right. You start to think of all sorts of different things. And most women who come in that are brave enough, I suppose, to tell me that they have those problems or that's what they feel. And of course, as you get more experience, you start to ask instead of just wait for them to give that information. But still, those people that are brave enough to you know, let it out of them, a lot of it is just that misinformation, I think. And then, like I said, if you start to think that something's really wrong, it starts to feel even more wrong, and nothing's been done about it for so long that it becomes this big point. And I do think, do you agree, Jo, that the external stuff, certainly any sort of tearing external trauma that has not, I suppose, I'm not going to say healed right, but isn't feeling right, can get better. In terms of the internal stuff, that can be a little bit different, but a lot of it, I think, is sometimes that it is just low tone as well. So it doesn't, it's a bit more open than it was before, in which case, certainly working on pelvic floor, if we find that to be the case, can help to tighten it all back up again and increase their sensation and therefore their sexual experience.
Yeah.
So it's also about, I guess, coming back to with birth, is our return to exercise. I'd love one of you to touch on the guidelines of return to exercise, which still horrify me. Returning to exercise after birth. And I think, which country is it where you actually get 6 sessions with a women's health physio?
France.
As part of your Medicare system over there. 8. Right.
Yeah.
So then every woman has the opportunity to be assessed by a physiotherapist. And I think it's really important here to say, well, you know, like you just said before, Jo, doctors have their place, and they're amazing at surgery and like taking care of the wound healing and stuff, but they do not have any experience of how muscles work in space and how the muscles should feel in terms of tone. And you know, so everyone in their different fields has their specialty.
Yeah.
And like, you know, I would say I don't have the experience of touch like you guys have. So I would always refer out to you guys for that, whereas I probably have more of an understanding of movement than you guys, because I watch people pick up heavy weights all the day, you know, and it's so important for us to all work together in this space to help people. So I think it's really important to know that your doctor can only know so much about you after birth. And so what do you I mean, first of all, what are the guidelines? and why are they not enough?
Well, if I'm honest, I couldn't really tell you what to say because I don't guidelines. I mean, guidelines have their place, of course, but really every woman has their own guideline. If you've assessed them properly, every woman will have their own guideline. You cannot put a blanket rule on when or how someone should return to exercise because their bodies are going to be different and the level of exercise that they want to get back to will be different. So quite honestly, I don't care really what the guidelines say. What I care about is that women come and be assessed by a women's health physio before they attempt to return as opposed to waiting until there's a problem. And I think that's what physios do well, is we're always trying to think about how could we prevent? How could we prevent? And I don't know, where we live, obviously, people have great health literacy. So we're lucky. We get to see these people. They are coming. They are listening to this message of that, and partly because their health professionals are telling them to. So, you know, OBs and midwives and so forth are also proactive in referring people. So because the reality is at 6 weeks post-birth, we don't know what your body is going to be like. Quite honestly, it could need work and it may not. If you've had a good pregnancy and a good birth, we're delighted that sometimes we can see someone at 6 weeks and can't find anything in their body that we need to treat. And then we'll design their guide. So we're not going to be stupid and say, well, your body's great. You can go back to CrossFit now because we're bearing in mind they've not trained. But like any athlete in any other sort of space, if they've not trained like that for 12 months because they've been pregnant and had a baby, then you have to start them back cleverly. You know, you're not going to they're not going back to what they did 12 months ago. They're starting at a certain level and you'll build them back up to whatever it is, running, you know, netball, whatever it is. You'll think about what they need to do and you'll think about what you think their body has capacity to cope without injuring themselves. Does that make sense?
Yeah, it's just pacing, isn't it, Jo? Really, you know,
yeah, I guess so.
Normal pacing.
Normal pacing, but with a level of individuality, you know, this body needs this. So does that make sense? Everyone's kind of got their own little guide. And returning to running just because you're 6 weeks post-birth is not an okay thing to do.
And it's that, I know it's so hard because I know so many of us women, I'm going to say us women because I'm a normal woman who has a certain belief about how I should look. And, you know, there's always a part of your ego that's like, oh, I need to get my pre-baby body back. But I really wish that women would take more time in this phase of getting a checkup with a women's health physio, you know, spending a lot of time getting sleep, nourishing themselves while they're giving away so much breastfeeding, and also understanding how much breastfeeding changes our physiology, like this position that we sit in when we breastfeed, and having, like for me, I think I was a C cup and then I was an F cup, like how our physiology changes with extra load strapped in the front of your chest. I'm not just going to go and run with that. You know, it's all about honouring our body where it's at, right? And nurturing it and understanding that there's always going to be time later to get those fitness goals. Like the women that I have worked with that went, you know what, I'm just going to take it slow for that breastfeeding period, and I've got the rest of my life to train. I've got the rest of my life to train and get lean and strong and fit and whatever it is that you want to do. But being the ones that have come out of birth with a strong, stable body, which I think is super, super important. Can we talk a bit about pelvic floor and what it works with? Because it doesn't work on its own, and especially in birth, we've had a lot of displacement of organs and fascia and muscles. And can we talk a little bit about it more globally? So people might, because I think as well some of those things, right, can give us an indication of pelvic floor or the abdominal wall being not at optimal function, rather than just thinking about whether we can or cannot hold our wee, for instance.
Yeah, totally. I mean, it's so, I think the more you do it, the more you think, well, it works with everything. So it's hard, but it certainly works with, of course, the abdominal wall, and it works very closely with the diaphragm. And they're all working, as Joe was saying at the beginning, all day long. So tonically, and they think about what you're about to do, and they'll change what they're doing based off whatever it is that you're doing. So you don't have to think about them so much, mind you. Of course, sometimes, given life happens and things happen in your life, often those muscles then don't work quite so well. So if you're thinking about, I suppose, how else we can, I suppose, pick in a person's body that maybe their pelvic floor wouldn't be great, is looking at their breathing to a degree. So if they're not breathing well, my guess is that often, and it's not always, but I'd be thinking that maybe their pelvic floor may not be so optimal either. It's the same with the hips. I mean, the hips, I suppose, have the most direct link in with the pelvic floor, because we've got the floor and we've got the levators like Joe was talking about, but we've also got the wall of the pelvis. And we can actually get to one of the hip muscles, which is a pelvic wall muscle, via an internal. So it's called obturator internus. It's up on the side. And this is the hip muscle. Mm-hmm. So if we feel that in a person's body that the hip isn't in a great position, often it's more forwards than it should be in its socket, then my guess is that that muscle could be a little bit tight. And that tightness there is the wall, and it connects directly into the floor, which then often feeds into the pelvic floor and trigger points and tight points through there. So you got the hip, and of course the pelvis with the abdominal wall. And we know those deeper abdominal muscles, so TA, work with the floor. The diaphragm works with the floor, so picking up people's breathing can give you an indicator as to whether something's going on with the floor. But even as far away as the jaw and the feet. Mm-hmm. And we know that, well, there's actually links between tight feet and incontinence. So we're looking at that in all of our incontinent women. So there's something about the feet and linking in to the pelvic floor, and therefore then the symptom of incontinence. And in terms of the jaw, I'm not sure about actual research, but clinical data tells us that often people with tight pelvic floors have tight jaws too, so they grip with their jaws. There's this, I'm sure this has to be one of your diagrams, is it, Leila?
Yeah, one of your diagrams, yeah.
Yeah. Well, that makes sense. So,
well, Joe and I are actually working on an interesting patient together at the moment who has this, and we haven't spoken to Joe for the last few weeks, but now that she's at home and schooling children and trying to run a business as well, and I'm trying to get her outside to do her steps every day for mental sanity, but also, you know, it's really important that we keep moving all day. I've certainly noticed since I've gone online the difference in my physiology as opposed to being in the gym and on my feet all day with patients. It's, you know, exercise is important, but making sure that we're constantly moving all day is important too. And that's actually affecting the work that we're doing on her pelvic floor because of what's going on with her feet. You know, so, and it's as someone program designing, it's like, okay, well, I've got to hit mental health, I've got to hit aerobic capacity, I've got to hit pelvic floor health, and it's trying to program design and do it in stages for someone so that they can achieve all of these things. And so we've actually been discussing this week about maybe seeing a podiatrist and getting a better shoe fitted, because I want her to be able to do the steps. And I want her to be able to walk and focus on her breathing and having mental space and not worrying about her pelvic floor. So not coming home after doing 1,000 steps and needing to pee. Or we look at the device that Joe was showing me that she could put in. So there are I think it's really important to work with people who can understand what your problem is, and because problems are meant to be solved, and understand what your goals are and space that out for you, because there's so many lifestyle factors that we need to consider. And so, you know, she still wants to have a workout where she feels that sweatiness, and so, but it's not okay to run now, but how can I create that for her in a training program where she's not loading her pelvic floor? All these kind of factors come in. And Susie and I were talking about in the podcast previously that we need this dream team where we all work together, because you just can't know everything.
Well, as Tam said, we're sort of working. We're working really hard with our team, and certainly with our mentor program to try and sort of, you know, I guess just teach this broad way of thinking about the pelvic floor rather than just its own little entity inside the pelvis. So hopefully there'll be a bigger pool of people.
Well, she's really interesting, like too, Jo, because she's got like a really tight rear pelvic wall, but a really lax anterior. So the front wall is lax, and so it's amazing, right? I've not had that experience before working with someone. You probably have, because you've seen so many more pelvic floors. But
what happens is, in her case, because she's got a foot and a hip issue, they drive the tension in that back part of the pelvic floor that you're talking about. And when that's tense, her pelvic floor doesn't work. So what I mean is, if I was to assess the function of her pelvic floor, she was probably about a 1 out of 5, if 5 was the grading scale and 5 was the best. And all we had to do to get her to a 4 out of 5 was release that back, right? So once we release the back and we can get the function in the muscle back, so we release off the tension, now she can contract her pelvic floor. Now that pelvic floor function will control that front wall better. Yeah. So she's good then. She's good. She does it now. Now I would say to her, now you can do your pelvic floor exercises, because I do want you to keep it at a 4. In fact, if we could get it to a 5 because you want to be so active, that would be better. La, 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 la. But I can't not treat her foot and hip as well if it needs it, because if the foot and hip stays bad, it will just wind the pelvic floor up, and then we're back to a weak, I don't want to say weak, but a dysfunctional pelvic floor again. So yes, so that's sort of not an unusual case, I suppose, for us anymore, that link.
No, it's not. And it's always look at this whole body. And I think that is something for women to question, right? If they're continuously needing treatment of a specific area and just constantly having passive treatment, to do some investigating or work with someone that can look at the body in a more holistic piece. Because, you know, and there's certain situations, right? Like we were talking to this client and she finds wearing high heels really stimulating for her continence. And so it's so much being driven by the feet. And she had been to see, I think, 3 other pelvic floor people who all said there was nothing wrong with her. And it's so disempowering when you're a corporate woman who presents and you're standing on stage in your high heels and you wet your pants, like, and that's not normal.
No, you know it's definitely happening, right?
Yeah. It wasn't. It was just a trickle. It was not a. But this is what I'm super passionate about, is women, be it corporate, athletes, stay-at-home mums, coming out of birth and feeling like they get their strength. And I'm not going to say strength back, because I actually think, for me personally, my body's better after birth because I did the work with Jo. Actually, Tamara treated me a few times as well, just as evil with those fingers as chopping on those trigger points. But, I actually came out of it stronger and better and with less pelvic issues than I went into birth with. And
it's often the way, if you've had a tight pelvic floor, if you birth well, then it just stretches it a bit and then it's back to normal, back to
so
the way.
Much better.
Optimal, back to optimal.
So, yeah, I think it's common to have issues. I really like this term, that it's common to have issues, but it's not normal to have issues. And that I think we need to raise the bar on our level of expectancy of what we can be capable with after birth if we have the right treatment and have the assessment. So I think another myth that I really want to talk about as well is C-sections, because I had a gynecologist once who told me that he preferred them because they were better for your pelvic floor. Needless to say, I didn't want him delivering my babies, but
yeah.
Ladies like to comment.
I'll take that one. So I mean, I think what he probably was thinking is that, of course, if the baby does not come down and through your pelvic floor, so not born vaginally, then it will definitely be intact in that it will all be connected. And in terms of, I suppose, macro trauma that can happen sometimes, that will not. But most certainly, of course, a Caesar is a big operation, bigger than I think anyone gives it credit for, and such a unique one to have this massive operation, be awake for starters, and then look after a baby afterwards. So you don't really prioritize, I suppose, yourself, generally speaking, in that circumstance. But what we find is that, or certainly what I find, is that after a Caesar, it is much more likely to have a hypertonic or high tone pelvic floor. But that's just because if you operated on any area of the body, if you operated on a person's shoulder, we would not then expect the shoulder to be amazing and like freely moving and all the muscles perfect. This is a, lower segment pelvic operation. So of course your pelvic floor is going to tighten up a little bit in response to that situation. So I'm often finding, not always, honestly, definitely not always, but quite often finding that it's dysfunctional in that it is tight. And they'll often then get things that are associated, I suppose, with the tight pelvic floor, which is dyspareunia. So pain with sex again, difficulty with tampons if they've left it that long and they've gone back to having their periods. And that's non-optimal. And they're confused by that, of course, because nothing came through. Why is it all different, So it's definitely not, I suppose, a Caesar. That is a myth that your pelvic floor is going to be completely preserved. It just is dysfunctional in a different way, potentially. Yeah.
And are you guys working with C-section scars as well and treating women after birth with C-sections?
Yeah.
And do you want to talk a little bit about that? Because I think, all the women I've had that have C-sections, I really want them, probably even more than the women who had vaginal births, to get treatment and get that abdominal wall functioning. Can you please explain that and the importance of that and the connection with the pelvic floor and, why so many women get back pain after C-sections? And
yeah. Do you want to take that, Jo, or I'm happy to?
So basically, by virtue of the simple fact that where the incision is in the C-section, we find that the abdominal wall function is just much slower to return, and requires just a bit more rehab, both from the perspective of getting the transverse abdominis muscle functioning again, booting it back up, and then layering on enough load. So it just feels like the whole system takes longer to get back. So that could be one potential cause for the back pain. Mm-hmm. If the women don't rehabilitate it appropriately, and they do need to, their TA function just gets shut down. It doesn't bounce back as well as people who don't have a Caesar. So most women who don't have a Caesar, you tend to see it bounces back, particularly if you've had the opportunity to work with them in pregnancy. So we do need to spend a bit of time on getting that baseline right. If they haven't done that, then, of course, your system needs to compensate for the lack of activity around your deep core system. And so might be another reason why the pelvic floor decides to wind up. But also what happens is your upper abdominal wall, so your oblique system, particularly external oblique, winds up, becomes dominant. Mm. And because that oblique attaches right up high to your fifth rib, you end up with this really cranky, compressed thorax, because these muscles are doing more than their job, which is just to rotate your trunk. They're trying to stabilize you as well. So that's another cause of the back pain, kind of particularly, you particularly see that back pain in the thorax that you're talking about. In terms of the scars, that's tricky. It's tricky because scars always cause adhesions. And so we don't know really the level to which that contributes to the dysfunction in the abdominal wall, the pelvic floor. It just is a bit experimental, so if you release off that scar, then what happens? Is that a contributing factor as to whether or not you need to layer in that type of therapy?
So I think Susie addressed it in a previous episode about C-section scars and what she's seen with patients, 10, 20 years later. So that'd be interesting for people to listen to. And she's very passionate about scar treatment and fascia, but probably maybe not something you guys are seeing as well, because if people are 10, 20 years post, they might be seeing a physio for something else, right? Not necessarily.
Well, but also, we're probably just not looking for it enough.
Yeah.
We will listen to Susie's podcast and start looking for it.
She keeps asking me if she can come to Sydney. Can I hook her up with you so she can teach you what you do? Teach her what you do. So just have a little.
Do it.
Really? Do you reckon she'll let me?
Only if she teaches us the scar stuff.
But yeah, right. Okay. See, isn't this beautiful? This wealth of practitioners. It's just interesting. And I think always something for people to consider. But I think as well, in that abdominal wall function that you're talking about, Jo, from an exercise perspective, when I'm seeing women who are saying to me they're unhappy with the aesthetic look of their belly, and I think for women this is quite normal. It's nothing to be ashamed of, and say I wish my tummy looked different, because I believe that if you have a great exercise program that understands how this all changes and that, most of the stretching, would I be correct in saying this, ladies? Most of the stretching is the lower abdominal section. And I think most gym programs address upper abdominals. And so we have this imbalance of not getting that tone back and function back in the lower abdominals. And this is where women are getting that poochy belly, and like you're talking about, the rib cage being really tight, and we see that small sternocostal angle, so the angle of the ribs is smaller. And so all of that exercising, where we're constantly doing crunches from the floor and things like that, is exacerbating actually this poochy belly, whereas women are thinking that, if I keep doing all this ab work, my stomach will get stronger.
It's devastating, isn't it, doing all that ab work and then still having that poochy lower belly? So we call that a pressure belly, because it really is, isn't it? It's if you're tight, when it's meant to be 90 degrees, that angle up the top of the ribs there, so it's meant to be open. If you look at the Olympians, right, the weightlifters, they're amazing,
beautiful.
And actually all the athletes, 90-degree angle for their upper, the infrasternal angle, so that angle of the ribs up the top there. It's meant to be that wide. If it reduces, that is then tightness, and that tightness causes pressure to go down, and it's going to come out somewhere. It's either going to come out your vagina or it's going to come out your lower stomach, honestly. And, well, it's probably more optimal that it comes out your lower stomach. And if you keep doing, I suppose I would argue it's not always necessarily the exercise. It's not the sit-ups fault, unfortunately. It's just that when you're doing it, you're not thinking about this angle up here, and you're just doing it with this tiny angle all the time. So sit up with the tiny angle, sit up with the tiny angle. But if we cue them, and I'm sure you do this a lot, Leela, like to open that angle and loosen the tight stuff and open that angle, the sit-up then becomes okay, because the lower abs just naturally start to work a little bit more, and it will stop the pressure going down, stop that poochy lower stomach. But absolutely less is more as well, quite often in that type of body. And it's more about balancing those angles, getting rid of tight stuff, getting them to breathe more optimally. And then, of course, in order to do it right, you really can only do like 2 sit-ups.
That's right, exactly right. That's why I find doing sit-ups over a ball is really helpful, because you can well, first of all, our rectus abdominis has a certain amount of contribution to extension. So if we're always doing crunches from the floor, we're never working our full rectus abdominis. But going back into that extension over a ball, you can get the ribs really open, and often with a client I will get under their ribs and really release that for them so they can get that sternocostal angle open more. And then you're also looking at, sometimes it's a bit of palpation with the lower abdominal wall because people just don't understand what that feels like to contract the lower abdominals to help them do a sit-up properly. And I just think it's so important, like everything, to build foundations and go through everything slowly, one part at a time. Like the more we rush things and skip over things, the more we end up with problems later in life. Like it's so hard to be a really fit athletic woman and be told that you can't do abdominal exercises anymore and you have to stop, breathe, and you have to breathe, and you have to, like, it's hard. You're like, but I can CrossFit and I can do all this stuff, and you want me to stop and loosen my ribs, and like that's
I know.
do it when
get
you
the buy-in from the aesthetics though, don't you think? You're like, the pooch will go.
Yeah, totally. Everyone's aesthetically driven. There's a whole psychology behind that, 100%. What about diastases? Now, this is something I certainly learned so much more about from you guys, because I had the great honour of sitting in on the girls' diastases course and actually getting to palpate some and look at movement under ultrasound, which I think is super important, right? When women get assessed, that they're being assessed with ultrasound, with an internal assessment. And as a practitioner, like I can feel someone's abdominal wall and how they're breathing, and when they're at a squat, I can feel it, but I don't touch people all day like you girls do, so I always refer out to make sure that that's what I'm feeling is what you guys are feeling, and also you guys have the ultrasound. But what is diastases, and what can we do about it? What do we know about it? And can we prevent it as well in birth? And so for the lay people listening, this is when we have a separation of the abdominal wall. And I think most people know is how many fingers they can get inside. I think more women are knowing about that, right?
You take this one,
Joe? Oh, you want me? Yeah, more women are definitely, almost too many, I would argue, know about it these days. But what it is, absolutely, you're right, is a gap in, I suppose, the two rectus abdominis muscles. It is, though, a thing that sits under there that they're feeling, this, space in the middle, this separation, and that is the linea alba, which is a bit of connective tissue. So you've got your muscles, and the linea alba is in the center. Before you have babies, often it's not that wide, and then afterwards, of course, because the baby pushes on the abdominal wall and you get hormones to make everything more flexible, thank God, so you can house that baby, but that bit of connective tissue stretches wider. As it widens, it thins, and that's why it feels like there's that gap. And we know that gap remains postpartum, and it's completely normal for it to, up until about 12 weeks. It will self-recover without us doing anything to help it.
Mm-hmm.
Yeah. And I forget what the other questions were, sorry.
Prevention. Prevention.
Yeah.
Are you seeing it more in women who, because I know it was something that Joe and I talked about when I was pregnant, because I was a bit of a gripper.
Yeah.
And it was something that I really focused on working under Joe's guidance, was relaxing my abdominal wall. Can you talk, is it something that you're seeing more prevalent in muscular women? Tell me about it.
Yeah, it's a fun thing. I think there's two groups when it comes to looking at women when they're pregnant, and I suppose trying to prevent the separation from getting too wide. And you do want to prevent it from getting too wide, because if it gets wider and wider and wider, it thins and thins and thins more, and it's hard to thicken it back up afterwards, so postpartum. So less wide, less thin is better. But yeah, two groups of people. So you've got your first group, which are your CrossFitters, high fit women. Now, they have such good linea albas because they have just trained and loaded it, right? So their muscles are tight, their linea alba is tight, And that gets them through that first and second trimester, generally speaking. But as soon as they hit that third trimester, the baby is still going to grow, right? And if your muscles are tight, then they can't lengthen as well this way. So that means the linear alba has to widen in order to allow that baby to grow and to get bigger. So what we find with those women, and the earlier the better, it doesn't have to obviously be by that third trimester, is we get them to let go. So they're often not only just tight through those muscles, but they're gripping through those muscles. So holding them on all the time because they're used to just turning everything on in order to perform whatever amazing movements they can perform, but just simply getting them to, I suppose, be aware and understand that they should be letting it go, like let your belly go, be pregnant. Then all of a sudden, rectus and the obliques, they can lengthen and take up, I suppose, a degree of that length that needs to happen for the baby to grow. And then the linear alba doesn't have to, and it doesn't widen all that much. And in fact, in those women, given they had such high quality linear albas to begin with, they do so well because there's just so much tone through the linear alba. It doesn't stretch all that much. They've let go of their muscles. And of course, we give them tons and tons of stretches. So, and we loosen through their abdominal wall, through their rib cage, because that's obviously where the abdominal muscles insert up into. And we think if we get them in time, they do well. But the second group, your second time mothers, generally speaking, or even maybe your really hypermobile women, it depends though, but certainly second time and third time mothers, those that have had a stomach that have stretched before. So in fact, their muscles are low tone. So they've been stretched. They haven't quite maybe rehabbed them back in to be tight again. The linear alba might be a little bit, I suppose, still stretched or still thin because again, they haven't had a lot of time. And this is especially true if they haven't had a big gap between their babies. And I'm seeing that more with COVID. They're like 6 months and then pregnant again. It's just stretched and now it's going to stretch again. So they're lower tone. And in fact, it's almost like, by 20 weeks, because their stomach has no tone, it can't hold the baby in. So the baby just flops out and their belly gets more and more stretched, which means then, of course, the linear alba just widens and widens and widens. So for these people, we actually end up training them a little bit and supporting them with tubey grip and stuff to hold their stomach in so that the pressure doesn't widen that linear alba. But both we think we can help, and certainly by helping them, we can prevent, we think anyway, it getting as bad as it potentially could.
It's so important to do in pregnancy again. And what about women who have had this? Because I think there's a lot of women that, my stomach just never went back to normal, like 10 years later. What can we do for those women?
Do you want to take that one, Jo?
Yeah, sure. We can treat them. We can 100% treat them. We just have to, again, just assess their body from scratch and figure out what we're dealing with, really. Generally speaking, the reason we like to prevent them in pregnancy and what we say to them is it is 1,000 times easier to sort you out postnatally if we've addressed whatever issue we felt was a potential problem in the pregnancy. So partly because of the time, but also partly because the woman then hasn't had a chance to develop a whole lot of compensatory motor patterns. So by the time we see them 2 years postnatal and they're getting around to addressing their abdominal wall issue, which is fair enough because life's hard with a baby, fine. It's just a little bit more complicated to figure out what their issues are now. So generally speaking, there'll be something else in their body that we'll need to sort out to allow transverse abdominis to become active, available again, because it generally sort of just shuts down because it's been taken, the stability system has been compensated for. So I guess we just find that, we sort that, we up-train TA. Once we know we've got TA, then we just figure out what loading patterns we want to put them through. So what we'll need now, if they haven't done much for 2 years, is probably a fair bit of well thought through load so that they can improve the tone of their abdominal wall. And then that obviously feeds into the linear alba, at which will lay down more collagen into that piece of fascia. And, the muscles feed into the fascia, fascia lays down more collagen, fascia gets thicker. Yep, and then we have a better integrity of the fascia and a better functioning piece of fascia or linear alba. So 100% just takes a little bit more time. It's a bit more complicated.
I think it's I understand there's a sequence of everything, right? It's not just about switching everything on and flexing and when you
then you'll get the poochy belly.
Not the aesthetics we're after.
Yeah. No, it's not. It's a lot about aesthetics. So yeah, it's that taking that time and I think the best thing you can work on postpartum, right, is your breathing. Like doing abdominal wall breathing and getting all those muscles moving, and especially, once you have passed that period with a C-section, because I think the problem with scarring, right, is that as adhesions develop when we don't have movement there, and the safest movement you can do after a C-section is to breathe into your belly.
Same after a vaginal delivery, I reckon, because you don't know what to do with the pelvic floor, but if you breathe well, then your belly will move and your pelvic floor will move a little bit. So I agree. Good exercise.
Do you think the positions we sit in breastfeeding have a big...
Oh, yeah, they're terrible.
Yeah.
I mean, honestly, if you we have something come out vagina, stitches, and then we sit on it. Yeah. It's like spraining your ankle, it being cut, stitching it, and then going home and sitting on it. It's really weird. So
yeah. It's just that teaching women to feed inside lie is a bit of a mission, but it's a big mission if people have the time to do it. It doesn't get taught in hospital, right? So people find breastfeeding hard enough. And if they're not taught from scratch a certain way, then it's like, don't tell me now I have to learn a new skill. I've just got the hang of this one. And it is a skill. If you've ever fed inside lying, you'll know what we mean. It doesn't come naturally. You have to faff around with which boob, you know. But, lots of women's health physios are very proactive in trying to get women off their perineum after they've pushed a baby through it.
Yeah, because we have this whole thing, like you almost get a trophy for as quick as you can return back to normal life, like if you see a woman who's just popped a baby out, she's walking around and everyone's like, oh my God, you're amazing.
It is true. I do get shocked though.
I know. But
because I was not like that.
I bet you that all they want to do is put their hand in their crutch and just like hold it.
Yeah, that's what I wanted to do. That was for sure.
But it's like going again, not giving out trophies for speeding through things. Like I'd love it if we actually gave out trophies for families who created an environment where women could stay home and side lie breastfeeding and sleep a little bit more and, do that whole 40 days of less activity. I don't know if I'd want to stay inside for 40 days after being in lockdown again. But, maybe just a bit of a slowdown.
Maybe that's what COVID's given us to those women.
Well,
the house. Everyone's at home.
Everyone's at home. Everyone's at home. I think there's something beautiful about that. The other thing I wanted to ask you, so when we are talking about a pelvic floor exercise, a contraction and a relaxation, can you describe how someone would do one and what it should feel like? So for all those women who've been sitting there doing their Kegels at their computer because that's what they thought they were meant to be doing.
I always explain it, and I think you never do know what's going to work for any one person. So what I always start with, and Jo may be completely different, I think we're all different, and as soon as we feel what happens, and that I suppose is the importance of the internal in the end, so that we know and that you are actually doing the right thing. If I feel that they do something completely different, I'll just switch to a different cue straight away. But I'll always explain that there's two layers. There's an outside squeeze layer and a deeper lift layer. And that first it must squeeze and then it should lift and then it should drop and then it should open. So it's the squeeze and the lift and the drop and the open, and all four components are equally as important as each other. Do you use anything else from the get-go, Jo? Like
no, I probably I think the only thing I do that you do too, you just didn't say it, is we cue almost more what not to do days before we even start with what Tam was just saying. So before that, you've said, okay, your hand is on your upper belly, just under your rib cage. Those muscles will stay quiet. Often I'll get the other hand on your bum, you know, up and around your hip and your tailbone. Those muscles will stay quiet. Nothing happens here. These muscles live inside your pelvis and then go on to give that same cue. And so because I think we just feel so much dysfunction, and one thing I suppose we haven't touched on is the fact that the pelvic floor works in isolation as well. And when we're testing it, we're testing an isolated levator ani contraction. We don't want it to co-contract with external oblique, and we don't want it to co-contract with your deep hip external rotators. But they are just common patterns that people develop over time. So you first clear that and make sure that their contraction's isolated and then roll forward.
Mm. And what about, I want to come back and do another episode with you guys and talk about pelvic floor in the athletic space, because it is quite a different, we are seeing a lot of athletes with continence issues that have had children, not had children. Well, it's going to be a whole other thing to talk about. But women who are training, like, what do you think is safe is in training in pregnancy?
No. I'll let you take that one, Jo.
Oh, yeah, of course you do. What do we think is safe in terms of exercise in pregnancy? Okay, well, I mean, again, it's a bit like the return to exercise guidelines. So you're talking now about the pregnancy exercise guidelines, which essentially say, do as you've always done, just don't start anything new, which we disagree with, because it depends, of course, what you always did. So sure, there are modifications that we think need to be made for some people's exercise routine, not because it affects the baby. And that's really what the guidelines were about. What happens to the fetus as it's growing? Oh, nothing really. It's fine. Play on. But we go, well, what happens to the mother's body? You know, we're busy trying to downtrain certain muscles to look after the linea alba, you know, and watch their hip and their pelvis to ensure they don't get pain, but also knowing that those muscles connect in with the levators. We really don't want them winding up and tight. And, you know, we've learned this over years because we've seen these athletes come in, or these Pilates instructors who've done so much of the same thing. And then we've assessed them and we've gone, holy smoke, there is some serious tension through here. So the reason we want to modify exercise is just for the sake of the mother's body, to prevent the things that we think we can prevent, and even potentially optimize their birth like we think maybe sometimes we can. So the answer, what is safe, is really depending on what they're doing. And I would say if you wanted to exercise at a high intensity in your pregnancy, that would be a good idea to be consulting with a physio at the same, women's health physio, through that process and figuring out a good plan. And we've done it. Like, we've definitely worked with high level athletes and figured out how we can best look after their bodies.
And I think it's most because the general exerciser wouldn't know what dysfunctions they had, and I think that's key. So if you were someone like, I knew I had a dysfunction, I just hadn't bloody done anything about it, which is like, you know, the worst practitioner thing ever, right? But it's like accountants not doing their tax and
I know what it was.
But if I had have not stopped, so I was deadlifting and doing yoga and gymnastics and all that kind of stuff. So if you could have said, well, Leela does all that stuff anyway, carry on, because it's not going to hurt the baby, because I'm not going to be, you know, increasing my heart rate too much, getting too hot, all that sort of stuff. But the truth is, if I had carried on, I would have just increased the tension in the tone of my pelvic floor and wound it up more. Because, do you want to explain that from your perspective, Jo? Like, and I'm happy to share part of my story. Like,
I mean, I suppose I could be bold and say, well, what we'd be talking about now is your birth trauma and how long your second stage was, and that you ended up with an avulsion of your, like a trauma to your pelvic floor muscles, and now you've got a big separation that we're really struggling to rehab.
Yeah. And I have heard so many women who are fit blame the incontinence issue or the prolapse issue that they have on the birth. And I always question, but they were still doing HIIT when they were pregnant and they were still doing all of these things. Did they ever get assessed to see what was happening to their pelvic floor in that exercise? And of course it changes throughout pregnancy, right? Like there's so much hormonal change. We could get better or worse during pregnancy. And so it's important, like I was consistently seeing you and consistently having the checkup to make sure I could relax. And what I worked out was that I couldn't continue to relax as you'd guided me to and train. Like I just couldn't do it.
Everything's getting looser, right? It's meant to. So if you're going to keep loading it with extreme weights, then the only chance your pelvic floor has, or the thing it should do, I suppose, is tighten up, hold it all in. But then, of course, we need it loose. It's meant to be loosening. So it is, yeah, as you said, it's a balance, I suppose. But as Jo said, it is different for each and every person. But I would urge everyone in their third trimester, at the very least, if you haven't, and you are a high fit person, I think, to get assessed, because yes, either you could be, I suppose, loading your pelvic fascia and organs too much, and or maybe they're fine, but they're fine because your floor is tight, holding it all up and in. And although you can do those things, you absolutely can, and people can, when they're pregnant, continue to be high fit. It just might not be the best thing for their body at that stage, especially if they want a vaginal delivery, and an efficient one at that.
And it's just always we come back to like the benefit to risk ratio, you know, and looking at long-term things. I know we're all so short-term focused and everyone's scared about pregnancy losing their baby body because it stretches out too much. So they have to keep training so they don't lose their tone. But that can actually be the opposite of what you want, because too much tone is not good either. And
they don't stretch well.
Yeah, you know, and we are designed, I believe personally, that we are designed to birth and we are designed to recover from birth. And it's our modern lifestyle that is not really accommodating that natural thing to happen. And that can be too much exercise as well as not enough exercise, or just the wrong kinds of exercise. Of course, there's a whole nutrition component with fascia and all of that stuff repairing, which we're not going to go into today. And I often question if that's a huge problem, because mums are just so time poor. They just don't eat enough food and enough of the right foods. But, yeah, there's so much that goes into it. And I just hope that this podcast really gets to a lot of women who just think that it's normal to have dysfunction. And especially because I know that's so emotional for a lot of women. Like sometimes I've spoken about it with women and they just break down. They're like, I didn't know I actually had permission to feel bad about this. You know, that's like I thought, I mean, you guys must see that all the time, right?
That's why we have tissues in our rooms.
All the time.
All the time.
Well, debriefing your birth story is such a powerful thing. And we will really welcome it in our clinic, A, because we love hearing birth stories, but B, because it's good for the woman. It's good for the woman to share. It's a big event. One could argue the biggest event of your life. And it's good to talk about it.
Well, I think as well, like it's a really judgmental space as well. I'm just going to come out there and say it's a really judgmental space. And I think a lot of people, when I was telling my birth story at my first mother's group, so I think there were, out of all of us, there were 2 of us that had vaginal deliveries in, 10 women. And I had an amazing birth experience. I did a hypnobirth and I did it all, you know, everything I could have wished for, I got. And I think that's not necessarily always the case, but I loved it. And when I shared that birth story in this mother's group, the midwife who was in charge of the group actually said I shouldn't tell people that story because I might upset other people.
It's a shame, isn't it? It's a shame. I mean, gosh, how is
Great
that?
mother's group.
Well, I mean, we can't, people who share their traumatic stories are allowed to share it. I think that's a bit unfair. You can't share your good story.
Well, I've always thought with birth that, there's not enough people sharing good stories. And I think we've come from this place where birth is meant to be painful and it's almost like a battle scar in a way. It's like talking about how bad your birth was and how, I saw some of the mums at school even like have a joke about, their pelvic floor's destroyed now. It's almost like a battle scar, of like a rite to passage as a mother or something. Like there's so many emotional connotations. Like I just really ask that women can just leave that all aside and go to someone like you guys who's just so beautiful at holding space for women, because the part of the healing from it is that emotional journey. Yeah. And yeah, like I said, telling your birth story or speaking to a counsellor about your birth story, or there's like beauty in all of it and there's trauma in all of it too. And trauma is a big part of healing.
Yeah. Now might be a good time for Tam to talk about Born Ready.
Yeah, I would love.
Well, I mean, if I just introduce it by saying part of the big reason why we created it in the first place was because, it just made us so sad to listen to these traumatic births or births that could have been better, We just would sit there going, what do you mean you didn't understand that? What do you mean? And the lack of knowledge that women have is just shocking. It's just not acceptable because women are smart. And we all know that knowledge gives you a sense of power. And so we just need women to go into their births feeling like they absolutely can do it, right, as opposed to scared or doubting themselves or going to be just guided by the midwife or OB. No, this is my birth and I'm going to own it and I'm going to do it because I've got a body that can. And so that's why we created Born Ready, and I'll let Tam talk about what that is.
Oh, we just love it because, as Jo said, that's why, because we just couldn't listen to it anymore. And knowledge is power, and we do think everyone can do it. It's a physiological process. So we also, though, think that there is, obviously this day and age, we do have a lot of assistance potentially available, and that isn't a bad thing in many respects. We're very lucky to have those options, because you can imagine being like 42 weeks pregnant and just like not in labor without the potential for induction and all the rest of it. That is a worse option than having those forms of assistance. But again, there's just things that we think women should know, and you need to know it so that you can give true informed consent. So Born Ready started off as that, just, I suppose, adding in bits that we know about the body, but the main focus was just all on, really empowering women to understand what their bodies can do about the birth process and about these facts when it comes to those forms of assistance, so that they can make the best plan for them. And that would be different for each and every person, but really giving them enough knowledge so that they don't just make their perfect plan, which I do find people do. Either that, they either make the perfect plan or they make no plan, one or the other. But I want a plan, I suppose, so that they're deciding what may happen on that day and what choice they would make if that thing happens. And hopefully that thing doesn't happen. Hopefully they're not induced. But what will they do if they are? Hopefully their second stage doesn't last for 2 hours. But what would they do if it did? Just so that on the day they have those decisions ready. They know what they're about. They're going to own it. And you know what I mean? It just flows a little bit more efficiently. But I suppose it's become more as time has gone on, because it is only 4 hours, a short course. We've realized that we are very good actually at preparing a woman's body, shock horror, for birth, and that this is something that is missed a lot in other courses. And this is an important part. I mean, you don't decide to run a marathon and not train, do you? Like it's a physical experience as well as an emotional and a mental one. So we prepare women's bodies in Born Ready, and we prepare their minds. We get them solid, and we want the partners there too, because they just help immensely, as you guys know, on the day. And it's a team event, birth. So we need their help too.
I think what I loved about your course, I mean, you didn't have the course when I gave birth, but you what the advice you gave me, you basically put into a course as I was seeing you over consecutive sessions, because I did come and sit the course afterwards, was that I had, it was options, right? Because nothing ever goes to plan. So I was like, okay, Jo, so what happens if this doesn't happen? And Jo was like, well, this is option B, and this is, option A, option B, and this is option, don't go there. And don't go there with confidence. Like, it is important to have those options. Because I think one of the biggest mistakes is women go in, just think that their body can just do it, for one, which is what I heard some really traumatic stories from my mother's group of girls that were just like, oh, well, everyone told me your body knows how to do it, so you just go there and it just does it. And they all ended up having every kind of intervention that you could possibly have, and a C-section in the end. Because for me, what I really got from doing it was that when I did the hypnobirthing is I spent an hour every single day in my third trimester doing like meditation. And because the biggest thing for me was learning that you have all these beliefs from generation after generation of generation that you have to switch off and not listen to. And that's essentially what hypnobirthing is to be able to go into that deep state of relaxation with none of that fear and projection from other people in your and at the back of your mind. And what I loved about your course is that you gave so much education and option, is that, like I've got friends who could not sit there for an hour and meditate every day before their birth, because that's just not their personality. And that's okay. Like there's no right way to birth. Like one of my neighbor was like, oh, she laughed at me. She was like, you're so adorable. You're like this earth mother. And I'm just like, give me the epidural and a burger at the end and I'm great. No tearing, no nothing. Just, but it's like we're all different and we all want to have a different experience, and there's no right or wrong experience. Like, and I really hope that women who have C-sections don't feel like there was anything wrong, because, as long as we have that informed consent, and I think this is where people get out of that trauma, right, where they go in and they go, well, I know what my options are. Like I was very clear on when I would say, yes, okay, please give me a C-section. Because I didn't want
beforehand.
I didn't want suction and I didn't want all that stuff. Jo and I had a big discussion about what is going to happen to my body if I have suction and all this sort of stuff. So tell me, Jo, I want you to tell me, when should I go, okay, C-section.
Yeah.
Because I wanted it to be about preserving my health and my body long term.
I think that's the point too. Like, we wouldn't give the same advice to everybody, because I knew what you wanted and what was important to you. Yeah, but it will be different to the next person. So, it might be that they say, I'll do anything to avoid a Caesar. That is my worst case scenario. Or, my abdominal wall is the most important thing in my life. I don't want to cut open. But for you, it was like, at the end of the day, I need to preserve my pelvic floor. So at what point do I call it? So it's just different for everybody, that discussion.
Yeah, like I really wanted to get back to being able to perform in an athletic capacity. So it's, how am I going to be able to do that? Yes, I have these dreams and aspirations, but at some point in reality, you need a plan B. But the awesome thing is that you guys aren't just educating women about birth, you're also educating personal trainers and physios as well. And I think educating personal trainers is awesome, because I think sometimes a person sees their personal trainer more than anyone else in their life.
Yes.
So they're like the best point of call to motivate someone to go and do something for themselves. So I love this. Can you please tell us about your personal training education?
Yes, sure. And then we've also rolled out a birth course for physios as well, actually. So I'll let Tam chat about that, because we're excited about that. That's our new course. But, we've worked with personal trainers and exercise professionals forever, and loved it. And absolutely the most interesting thing is that people are hugely influenced by their personal trainer. So it's been wonderful to work with them because, we'll say something and then tell the personal trainer, can you please incorporate this into your training? And then they listen to the personal trainer. So we go, okay, good. Whoever, I don't care. You listen to them, good. I'll tell them what I want you to do. But so we've worked with a lot of trainers, and sort of they've asked us a lot of questions, and we've happily shared our knowledge over the years, and equally learnt from you guys plenty as well. But we've just decided to put it all into one day and sort of help personal trainers go to a deeper level of understanding with regards to all things women's health from all life stages, from adolescence right through to postmenopause, and to understand everything from hormones and how that changes our bodies, and of course to understand normal pelvic floor, dysfunctional pelvic floor, why that's important for the job, and the same with the abdominal wall, normal functioning abdominal wall, dysfunctional, why that's important, and try and put it all together, coming from the perspective of, the health of a woman's body. And exercise is vital, so vital for so many health reasons. So we need to keep women exercising, but we just prefer it if we could keep them exercising well. That's all.
Absolutely key. And that's, I think it's a really important, because if your personal trainer is talking to Joe and Tamara, like, you can pace that recovery as well. Like, pacing recovery is so important, like not skipping steps. And I was really fortunate enough to sit on your physiotherapy, some of your physio course as well. Tamara, would you like to tell everyone about that? Because I'm hoping there's lots of physios that are listening that want to learn more as well.
Yeah, sure. I mean, currently we have our diastases and abdominal wall course. So that's the one you sat in on. That's been going for quite a few years now. So we love teaching that. So obviously it gives a lot of research, as you saw, so actual research, but a lot of, what should we call it? What do you call it? Clinical research, clinical
data, yeah.
Data, that's it, as well. So the stuff that we found that works over the years, not just for diastases, but also for people's abdominal walls. So addressing all of that, why is it still Gucci situation, and what you can look at. Think outside the box type stuff that we know works. But yes, what Joe was talking about before is that this year we're starting a birth prep for women's health physios as well. So basically it's just like a much longer version of Born Ready, essentially. So everything that we think women's health physios could know, so that they can then help women prepare better for their birth, so that then we can help more and more women have better births moving forward. So it's just, I think, our way at spreading that knowledge across as far and as wide as humanly possible, because we think we're very well placed to help women. But it's just not something that we get taught. Or everything that we learnt, Joe and I, preparing for Born Ready is on us. Like, we sorted it all out. We figured it all out. We experimented, and it's just not readily available. So that's what that one is. And we're probably most excited about that one, probably because it's new more than anything else.
And you're teaching a lot online now with this new world that we live in?
Where are we? Yes. So our next diastases will be online. Born Ready's been online. Anything that falls within a COVID time will be online, but if it is not in a COVID time, then it will not be online. That's our rule, because it's so hands-on and it's just practical. We're going to lose the art of, being with people and meeting people and socializing and, all that type of stuff. So if it has to be online, it will be, but otherwise they will not be any of our courses if we can avoid it.
Well, thanks so much, girls. So Joe and Tamara run the Physiotherapy Clinic in Sydney. And how many practices do you have now?
Three.
It's ever expanding, and an awesome team of both male and female physios. Oh, I forgot to ask you about male pelvic floors, Joe. The myth that it's only a woman's problem. Come on, quickly, tell me.
quickly. Okay, it's pretty easy. Males have a pelvic floor too. Generally speaking, they have far less issues when it comes to dysfunction, but they can. So how that presents is a bit differently in a man. Generally, they have issues with their bladder. So they'll be frequent. They'll have more frequency and more urgency. And of course, that relates to a hypertonic pelvic floor. So you can find men with a high-toned pelvic floor that drives bladder and sometimes bowel problems. And the other male cohort you see is men who have to have their prostate removed or prostatectomy because of cancer. What happens is the prostate actually offers a little bit more support to the urethra to keep the urethra closed and therefore the man continent. So they can lose their continence after that and need pelvic floor muscle retraining.
Okay. Do you do that, Jo?
We do.
Yes. Do. Yes, you do. It's just not as fun. I did have a male client too I was discussing with a colleague, and he actually found that when he had pain, testicular pain, and when he sat in water, it went away. So he had there's just so much. I hope men don't talk about things of my experience.
Yeah.
Of men. Women talk about things a lot more, but men don't talk about things, and there are, I think, a lot of issues down there that men can experience that you can reach out to someone like Jo for help with, and you won't look weird going to a clinic because there's sports physios and there's all sorts of things.
Yes.
No one will know what you're there for. Yeah.
For men, not just with men's health problems. Yes.
Yeah. So, please get that address, men, and if any women listening might be able to help their husband with something, don't suffer in silence with problems down there. But yes, tell me your website, your Instagram, all that stuff. I think Tam's the new marketing person, isn't she? I've seen you so much on Instagram lately, Tam. I love your videos. Yes, so you have to tell. I love your videos. So, yeah.
Thanks. So our website, it's www.physiotherapyclinic.com.au, and our Instagram handle is @Physiotherapy Clinic, I think. And I think when you don't type that out all the time, you start to think, is that it?
Is that it?
Is it Physio Clinic? No.
I think it might be Physio Clinic.
Okay, at Physio Clinic.
I'll put it in the show notes.
I know. Yeah.
And we've got one for Born Ready too. So @BornReady_Physio Clinic.
It's the Physiotherapy Clinic.
Oh, damn. It is Physiotherapy Clinic.
Yes, Physiotherapy Clinic. I've just looked it up.
Ew.
So
what would I know? Shut up.
No.
We'll try to get Jo doing some more videos, Leela.
I know. Come on, Jo. So, I would love it if you're listening and you got something out of this podcast that you would tag Physiotherapy Clinic or me, Leila Lutz, on Instagram and share with us what you've learnt. Please share this podcast so other people can feel empowered about learning to listen, how their body never lies, and getting empowered about their health. And thanks so much, Jo and Tamara, for coming on the show. This has been awesome.
Thanks for having us.
Great. Thanks, Leila.
I'm Leila Lutz, and you've been listening to The Body Never Lies. If you haven't yet, please go to your favourite podcast app and subscribe, rate and review this podcast. All the resources and references from this episode are waiting for you on my website, leilalutz.com. Just click on podcast and look for this episode. Now join me next week for another episode of The Body Never Lies. Thank you so much for listening.